Recording in progress. Good evening, all, and welcome to the National Symposia on changing paradigm in the management of type 2 diabetes and the role of triple drug fixed dose combination, that is remogliflozin, metformin, and vildagliptin. So I am Dr. Kiran Khadka. I am working as a medical advisor at Glenmark, and I take this opportunity to welcome all of you to this today's event, all the delegates, our esteemed speaker, my team at Glenmark. As all of you are aware that Glenmark has always been a leader in providing, working towards the improvement of patient healthcare and providing support to the healthcare professionals through various academic events like CMEs, webinars, and symposia. So today's symposia is on the background that Glenmark has received a DCGI approval for the first time unique fixed dose combination, triple dose combination of remogliflozin, vildagliptin, and metformin. So to have a better understanding, opinion regarding this triple drug combination, we are glad to have with us our today's eminent speaker, Dr. Faraz Farishta, sir. Welcome to the event, sir. Though there is no need for any introduction, but I take this opportunity to introduce sir in a brief. Sir is currently a managing director of FS Endocrine and Diabetes Center. Professor in Medcity Institute of Medical Sciences. Sir is currently chairman of Investigator Council for ICR. Executive committee member at IMA Hyderabad City branch. Sir is a consultant at Thumbe Hospital. Sir is a program chair for the Masters in Diabetes and Endocrinology at Texila American University. Sir also been a co-guide for PhD in Medicine by Research, Endocrinology and Diabetology program, PCMS USA. Sir is also associate editor of various journals, including Diabetes and Obesity International Journal. And sir also been a part of various global clinical trials as a principal investigator. So with this introduction, now I request Dr. Faraz Farishta, sir, to kindly enlighten us on this role of this triple drug combination in diabetes mellitus. Over to you, sir.
Thank you so much, Dr. Kiran, for this nice and warm introduction. And today, again, I think gives me an immense pleasure to talk on a very new subject. I know I still remember my first talk probably on SGLT2 inhibitors. Yes, since it was the EMPA which came first, and then of course speaking for RMO as well. I think in the last 5 years, with all the SGLT2s around, one thing which we all have is that this is the only drug in our armamentarium which is directly acting on the metabolic syndrome, so which is the major reason for having diabetes. So let's see what are the needs of an Indian type 2 diabetes management. So yes, whenever we talk about the ABCs, yes, lowering of the A1C, but for B, it is not the BP reduction, it is the beta cell preservation and durability of treatment. So whatever treatment we are giving, we should take care that it also preserves the existing beta cells which are already been hampered. C would be the clinical inertia. So there is a lot of clinical inertia at the patient's level, at the doctor's level, which takes, I would say, a lot of time for the patient to get the sugars under control, for which they have to pay a lot of price in the future. D is for the diligence towards treatment, that is the adherence, most important in a country like India. And E is the ease of the therapy and economy. So, of course, in a country like India, I'm sure we will never be able to do anything without the E, because whatever said and done, we're dealing with a chronic disease segment where the economy will still be a big factor in a country like India. And there is no surprises in this, but again, I think it is time for all of us to see this, that at the time of diagnosis, so you will see most of our Indian patients, what we diagnose are around 8.5 to 9% or little more than that, based on the various studies which have been done. And they are 2% more than target. So if you consider 7%, that itself says that most of our Indian patients at diagnosis are at 9 or more than 9. And then this is VMJ open real world evidence of glycemic control of type 2 diabetes, the TIDE study, which says only 35%, or I would say 30 to 32% of our patients reach the target goal. The rest of the 70 to 75% still are above the target of more than 7, because of which you will see they have around 35% microvascular risk complication, which is present at the time of diagnosis as well. So this is a typical, I would say, timeline in a diabetes patient's life, where you will see even before the diagnosis of diabetes, if you go on the left side of the graph, minus 10 years. So the effects you will see as early as minus 10 years, where the incretin effect and the beta cell function keeps on going down. And when the beta cell function loses around 50%, your patients present to you clinically. At that time, you will see from there on, there is a further decline which happens, because of which there is rise in the fasting, postprandial, and the ACEs. And typically, this was the pattern, I would say, uh, which was being used, that you start with lifestyle modification. One, blood sugars are not getting controlled, make it to twice, still not getting control, give it thrice, and then still not getting control, add a basal insulin. But now we all have known that early control is known to reduce the diabetes related morbidity and mortality. So you will see it is not only the macrovascular complications, but even the microvascular complications also come down. So you will see there is a reduction in myocardial infarction by 14%, stroke by around 12%, 43% reduction in the peripheral vascular disease, and 16% reduction in heart failure. So these speaks a lot of volume. For every 1% of A1C reduction, you are going to get all these benefits. So even if you are getting your patients from 9 to 8, you do a lot of good for your patients. And then across India, you will see there is low adherence rate to therapy. So even you will see in north, east, west, south, in the primary care or even at the tertiary care, the adherence still is hovering around 40 to 45%. That is the best adherence, I would say. The best what we have seen is around 55 to 60%. And then as the disease progresses, there is definitely requirement of more and more drugs which required to be added on patient's treatment. So you will see as the age goes on. So if somebody who is elderly, more than 65 years, will be requiring maybe more than 6 tablets to 8 tablets. That include the BP medications, that include the other medications as well, when you compare it with the younger individuals. And after defranzo's omnius octet, we all have realized that it is not only insulin deficiency or insulin resistance what we are dealing. There are 8 different pathophysiological mechanisms which are leading to hyperglycemia. And it is time that we start looking at each of them to have a drug which acts on all of these pathways. So till date, I would say we do not have one drug which will be able to act on all of them. So there would be multiple agents which would be required to act on all these arms. So combination therapy would be definitely more important, but they should have complementary mode of mechanism. So they should complement each other when we are giving a combination therapy. The benefits are they help us to attain the target very early, have a good glycemic control, they reduce the complications, delay the disease progression, and then we have seen that yes, the fixed dose combination gives our patient a better compliance. So let's see, of all the armamentarium drugs, right from metformin, I would say, to the latest kid on the block, the SGLT2 inhibitors, we have different drugs, and now we have different combinations of all of them as well. So let's see the effects of these drugs. When it comes to the A1C lowering, I think there is, I would say there is no debate as well as when it comes to oral hypoglycemic agent versus insulin. Insulin has the highest, followed by the sulfonylureas, then we have the metformin, then the GL2, GLP-1, DPP-4, all of them. The other more important parameter is the risk of hypoglycemia. So we all know in these drugs, the risk is highest with sulfonylurea and insulin. Coming to the body weight, again, metformin is a weight neutral drug, helps in weight loss. Similarly, with DPP-4, it is a weight neutral. SGL2, GLP-1 definitely have proven to have effect on weight. When it comes to the safety and tolerability, I think, yes, by and large, most of them are very good drugs when given for the right patient. Cost of therapy, again, in a country like India would still be a problem, but I think with newer molecules of SGL2 and DPP-4 inhibitors getting generic, these have come down tremendously. So it is not only about glycemic control. We all have realized that in the last, I would say, one decade only help us to reduce sugars, but they will also have pleiotropic benefits. So we have been looking at drugs which will help us to reduce the cardiovascular and renal burden as well. So if we have to have a combination which would have the benefits of all of them, I think now it is metformin, DPP-4 and SGL2. And particularly with I would say, introduction of remogliflozin, the price factor has come down, and the dapagliflozin also. And when it comes to the DPP-4 inhibitors, yes, because of vildagliptin going off patent, that also has helped tremendously in the cost control as well. So yes, this is a paper which said that combination fixed dose therapy, there was 26% decrease in the risk of non-compliance when compared to the single pill. So we all have seen that clinically as well. The fixed dose combination improves the adherence, there is higher persistence, and there is a smaller change in the number of drug prescriptions what the patient requires. How does it relate to clinically? I think this is the most important factor. Does it have any clinical implications? So yes, it does. Each 10% increase in adherence with anti-diabetic drug was associated with 0.1% A1C decrease. So you will see with all the drugs what you're giving, with just 10% increase in the adherence, the A1C reduction is around 0.1%. And with 10% decrease in the adherence, the A1C goes up by 0.14%. So this is a very important thing. We have to see that whatever drugs we are giving, we need to look at the adherence as well. So let's see the current drug combinations, what we have, metformin, sulfonylurea, and thiazolidone, I think I would say it's been there since long. Metformin, sulfonylureas, and AGIs. When it comes to mechanism of action, yes, they all have different mechanism of actions. Pharmacokinetics of the drugs must be similar, so they fit in that as well, but should not induce supraadditive toxicity. So this is where you will see uh, metformin, sulfonylurea, and thiazolidone scores are a little better when it comes to the other combination and recommendation of treatment guidelines. So we do not have many guidelines which are endorsing on all these combinations. Let's see the latest combination of metformin, SGL2, and DPP4. So you will see, except I would say the real-time benefit is the complementary mechanism of action, because when all the three are given together, they are, you will see, acting on 6 out of the 8 pathophysiological mechanisms which are leading to hyperglycemia. So that you can imagine one drug which is given us action on 6 different pathophysiological mechanisms which we never had. And coming to the latest guidelines, ACE 2020, even the 21, you will see the ADA standard of care. It clearly says that any patient who is not controlled after lifestyle therapy, you need to do the risk stratification, and these patients have to be started after metformin on GLP-1 or SGL2. Or any patient who has past history of CVD, a past history of heart failure, past history of nephropathy, these have to be directly started on SGL2 inhibitors after metformin therapy. So this is again very interesting. US FDA has already given approval, you will see, for the metformin, sitagliptin, and dapagliflozin combination. So there is Trijardi XR is a once daily treatment option, which is another combination which involves EMPA, Lina, and metformin. So we always talk about combinations in India, but you will see US FDA has also clearly given approval last year for this combination therapy as well. So what I was talking about, when we give all of them together, we are talking about holistic management of diabetes. They act through different mechanisms, so there are no drug-to-drug interactions. In fact, they have complementary synergistic mechanism of action when given it together. And we all know, I think in the last 5 years, we have seen the marvelous benefits of SGL2 inhibitors as a class of drug. They help in weight loss around 2 to 4 kgs. Higher the BMI, better weight reduction we have seen. I would definitely say 4 to 5 mm systolic blood pressure reduction we have seen clinically as well. And when it comes to heart and renal protection, I think now all the guidelines you will see are recommending these class of drugs for cardiorenal benefit. And then there is consistent SGL2 benefits which was observed in meta-analysis of the CVOT trials. So there is definitely a reduction in CV events. It is having a good reduction in heart failure, and it is also helping in preventing the progression of renal disease as well. And then this review article says the class effects of SGL2 inhibitors on cardiorenal outcomes. So I think we all have also understood that in the last 5 years that these drugs as a class have definite effects on the heart and the kidneys when given in a diabetic patient who has a previous history of heart failure or who has nephropathy. Let's see the CV safety of DPP4 inhibitors. I think we all know that, yes, most of the DPP4 inhibitors leaving saxagliptin are at least cardiovascular neutral. When it comes to the metformin therapy, UKPDA study has clearly shown the benefits of early glycemic control, and metformin independently has also shown some cardiovascular benefits. I think it is time that we all have realized that metformin is just not only for sugar controls. Yes, we were using it for PCOD. It's a very good drug for insulin, published of having some activity on neoplasm, probably an anti-aging medicine as well. So I think in the years to come, definitely we're going to see more and more benefits arising of metformin therapy as well. So there were past evidence to observed with the cardiovascular benefit with metformin, and metformin monotherapy was associated with lower risk of cardiovascular related morbidity and mortality. Let's see the cost effectiveness of DPP-4 inhibitors and SGL2 combination therapy for type 2 diabetic patients. Branded DPP-4 and SGL2, and pathway 2 is the generic alternative with sulfonylurea and insulin. So we all have seen that yes, generic medicines, I would say, have definitely helped our patients a lot. I would say they have made our job also very, because now we can give it to most of our patients who require the right drug because of reduction in the price. And now let me come to the most important aspect. Glenmark has got CDSCO approval to market the combination of Remo, Vilda, and metformin. So this is the combination of SGL2, DPP4, and metformin, which I was talking about, the triple drug therapy, which is acting on 6 out of the 8 pathophysiological mechanisms. So this is a forever phase 3 study. So it is a fixed dose combination of Remo, vildagliptin for efficacy and tolerability versus the, I would say, gold standard EMPA and LINA in patients with metformin failure. This was done across India, around 23 sites. So it was well spread across. So we have data coming across pan-India. It was a randomized, double-blind, double-dummy control trial in a parallel group, assessing the safety, assessing the glycemic control of Remo and Vilda with the comparator that was EMPA and LINA. So these was as an add-on therapy to Indian type 2 diabetic patients who were not responding to metformin therapy. So patients after the screening and randomization period were put either on Remo 100 plus Vilda 50 milligrams arm. Another arm, metformin was continued, and in the another arm, the patients were added on EMPA and LINA, and the patients were followed up for 16 weeks. And further, after the finishing of the period, the patients had to go in a follow-up period of 2 weeks. So you will see when it comes to the glycemic efficacy, there is hardly anything to choose between both of them. This proves the non-inferiority of the combination of Remo and Vilda when it compares to the, I would say, gold standard EMPA and LINA. Reduction in the fasting also, that was similar. Reduction in the postprandial, again, you will see was almost similar. Weight reduction, again, the weight reduction or the pleiotropic benefits you will see again was almost similar. You will see in both the groups starting from week 6 to week 16. Reduction in blood pressure also was seen with both of them. adverse events. So definitely drug-related adverse events were low, you will see in both the groups when you compare it with individually. So when it comes to the safety profile, there was no increased risk of hypoglycemia. There was low risk of genital tract infection versus a single SGL2 add-on therapy that we have already seen. And genital tract infection also was less when the combination therapy was used. So this clearly gives us an idea that this is non-inferior. And when it comes to the adverse events, it is similar. So it is non-inferior when it comes to the glycemic control. It is similar when it comes to the adverse events. And the pleiotropic benefit is also similar between both the groups. So the conclusion from Forever study, the triple drug therapy was observed to provide early and consistent glycemic reduction. The pleiotropic benefits, I would say the weight reduction, BP reduction beyond the glycemic control was seen with this combination when you compare it with the standard EMPA and LINA. Triple therapy is not observed to be associated with any additional safety risk. So rest be assured that whenever you are starting in a patient, you are not putting them at an additional risk of hypoglycemia. And all the findings have found to be comparable to the combination of metformin, EMPA, and LINA. So when it comes to the, I would say, glycemic reduction, it has clearly proven to be non-inferior. And individually, we have seen the benefits of all of them, metformin, SGL2, and DPP4 inhibitors. Individually, I think now over the years, we have seen the benefits of all the drugs. So when combined together, they are having that complementary synergistic mechanism of action, which will be, I would say, very good for your patients. And most of the guidelines, if we look at the guidelines, most of the guidelines says that any patient after metformin therapy with past history of heart failure with nephropathy has to go on a SGL2 inhibitors, still not getting controlled, you have to go down the line. So I would say now we have a drug which directly acts on the metabolic syndrome, and we also have a good synergistic combination which is helping us to do so, and it will definitely improve the patient compliance as well. So thank you so much for your patient listening.
Thank you. Thank you so much, sir, for this excellent talk and highlighting all the aspects related to the management of diabetes, the concerns related to the poor glycemia, particular needs in the management, and how this triple drug combination can tackle all those challenges. So thank you, sir. And now I open this forum for the Q&A session. So there are a few questions in the chat box. The first is,
yeah, you can take it now.
The first and most common question is about how much HbA1c reduction can we target with this triple drug combination?
See, the combination of EMPA and LINA, so their trials we have seen a reduction are around 1.5%. Some till 1.8% as well we have seen. So that is, I think that is what Forever study has shown, that this is non-inferior. So when you're giving it together for a diabetic patient who is, I would say, 2% more than our requirement, around 9%, you are bound to reach, I'm sure your patients will reach at least 7.5 when you're giving this as the combination therapy. So you can expect at least 1.5%, if not more.
Right, sir. So there is one more practical question about can this triple drug combination be initiated in newly diagnosed patients or drug naive patients? What's your opinion on that?
See, again, let me be very, very specific here. SGLT2 inhibitors are, I would say, the drug of present, will be the drug of future. But these are a set of drugs which cannot be started for everyone as a blanket therapy. They have their own set of indications where you have to use them. So in a naive patient, still you will see all the guidelines says metformin therapy. So I would say a naive patient without any complications, without any risk factors, metformin still has to be the first line of drug. If the patient is not getting controlled, if the patient has two or more risk factors, or patient is developing proteinuria, then definitely this could be your next drug of choice.
Right, right, sir. So basically, this has to be individualized.
It has to be individualized here.
So considering that, sir, so do you see the potential in this triple drug combination in near future? That could it be a baseline therapy and other therapies could be adjuvant therapy and they could be titrated as per the clinical need? Will that be a possibility?
See, if you take India, our way of practice, most of the time I have taken through the slides as well, we have patients who come to us with a bad control. So even if they are naive patients, we have seen they come to us at a 8.5 or 9. Hardly we have patients which come to us with 7 or 7.5. Most of the time, at least probably where we are practicing at the tertiary center, probably we get more of complicated patients. But overall, you see that, yes, we hardly get patients at 7 to 7.5. I would say most of our patients who are on metformin therapy, some patients on sulfonylureas with metformin therapy, not responding to the treatment, where the A1Cs are typically ranging between 7.5 to 9. So I will be very comfortable to start this combination in that group of patients. Anything above 9, 9.5, we all know these are patients who are insulinopenic. They will require insulin therapy, whatever said and done. So these combination therapy is not a replacement of insulin, but nevertheless, if you started in an insulin patient who is already taking insulin, this will definitely help them to reduce the dose of insulin. So your insulin dose could come down by around 25 to 30% that we have seen with most the SGLT2 inhibitors, and you will have that good glycemic control, and that glycemic variability will also be reduced.
Right, right, sir. So there is a one more question about hypoglycemia. So considering this is a combination of three classes, do you expect hypoglycemia with the patients?
Yeah, so you will see, I had just brushed through the slides. I did not go into the detail, but I will put a point there that individually, if you see the risk of hypoglycemia with metformin, it's hardly there. DPP4, again, it causes glucose-dependent insulin release. We know that the risk is almost negligent or not there. When it comes to SGLT2 inhibitors, also we have seen that. So when you're giving it together, the combination therapy risk of developing hypoglycemia would be similar if you are starting probably per se with somebody on a single SGLT2 inhibitors or a DPP4 inhibitor combination as well. So you are not increasing the risk of hypoglycemia, what the trials have also shown when you compare it with the individual therapies. Theoretically, there are studies which said that if you combine the SGLT2 inhibitors and DPP4 inhibitors, the risk of UTIs have come down. Theoretically. Practically, I would say most of us have not seen that till now. But theoretically, there have been papers which have been published because they say there is some active DPP4 activity in some of the E. coli or bacteria. So when you're giving this combination together, the DPP4, that activity is getting inhibited by the drug. So the risk of UTIs are definitely when you give it together as the SGL2 and DPP4 together is less when you compare it with single SGL2 inhibitor. So that benefit is there, but the risk of hypoglycemia is absolutely not there.
Right.
I would say increased risk. I think that would be the point.
Right. Right. So there is one more question regarding concerns. I mean, uh, usage of this triple drug combination in the renal and hepatic impaired patients.
Yeah. So again, see now if you see the guidelines, so if I talk about the renal patients, the KDIGO guidelines which have come as new as this year, now clearly says that you can use it safely till 30. In fact, now for DAPA, they have gone below that as well. But there is a clear-cut indication that you can use it till 30. You cannot initiate somebody at 30, but if somebody is already on that, you can continue till 30. So if even at, we are talking about EGFR of 30, that is severe renal insufficiency. Vildagliptin, again, as a once daily therapy, you can definitely give. You're not giving twice daily therapy. Of course, if it is a severe renal insufficiency, at that point, you can give it as once daily. Metformin, again, they have said that if it is between 30 to 60, you reduce the dose by 50%. And less than 30, of course, you cannot give metformin. So if it is less than 30, you cannot give the combination. Between 30 to 60, yes, you can give it definitely. And above 60, absolutely, you can give the full dose. There should not be any problem with the combination therapy. And if the OTPT, the SGOT or the SGPT, the hepatic parameters are more than 2 times the upper limit of normal, they're definitely, I would say, metformin and Vilda are not to be given. So if somebody is having a Hayward liver parameters, there it should never be given. Otherwise, it could be given safely.
Right, sir. Right. Thank you, sir. Thank you for clarifying this thing. The one last question, again, could be a practical question. Is there any concern related to this triple drug combination? Can be given before food, after food, any food drug interaction?
Yeah, see, again, probably there is nothing which hinders the absorption. If you see for all the three, you can give it before food, you can give it after food, unlike probably a combination of glimepiride, metformin, where you will have, or a pioglitazone or triple combination, where you probably because of the glimepiride, you might have to need it before food. But here, it is not related with the food administration. So you can give it before food, or the patient can take it after food as well.
Okay. So, sir, this could be a last question. So, sir, in a nutshell, where exactly do you see the role of this triple drug combination in a journey of a diabetic patient?
See, let us start from naive patient. So a naive patient, initially, we all see 7.5, they're maintaining good on metformin. And then we see that metformin starts failing and we will require a second drug of therapy. So at that point of the time, do the risk stratification of patients. Even at 7.5, if your patient is having 2 or more cardiovascular risk factors or is developing some form of proteinurias or has already probably developed some cardiovascular event, then these drugs could be started as early as 7.5 after metformin therapy. And they could be continued till 9. I'm sure it could be continued easily till 9%. When we are talking about only about glycemic control, let me be very clear. We're talking only about the glycemic benefits. 9, we can still continue, but over and above 9, probably we will require insulin therapy to get the glycemic benefits. But even above 9, so patients, I would give you a scenario: a patient who is on sulfonylurea, metformin, and basal insulin, has a past history of cardiovascular disease or is developing nephropathy. So we're talking about the, I would say, elderly patients who are already on these therapies. But now if you see the guidelines, it says you still need to add on these drugs to get the cardiorenal benefits, which we are not going to get with other class of drugs. So there, probably you can continue the basal insulin, you can withdraw the sulfonylurea, and then you can give this combination so that you maintain the glycemic levels and your patient gets that cardiorenal benefit as well.
Right. Perfect, sir. Thank you so much for giving this overview of the role of this triple drug combination. I guess there are no more questions in the chat box. So before wrapping up today's session, I would like to thank you, sir, for being here and highlighting so many issues and also the role of this fixed dose combination in a very elaborative manner. So thank you, sir, and also would like to thank our audience for participating actively and sharing your questions, thoughts, doubts, and thank you to sir for giving your candid responses to all the queries. So thank you, sir, for joining here, and thank you for taking time from your busy schedule and being here with us for almost 1 hour. So thank you, sir, for today's event. Thank you.
Thank you.
Thank you all. Have a good time.
To introduce for the first time in India a combination of SGLT2 inhibitor, DPP4 inhibitor and metformin, Glenmark Zoltan Care Team launching a match winner combination with 3 match winners in 1 pill: remogliflozin, metformin and vildagliptin. Remosin MV. 3 match winners, 1 pill.